Okay guys, I hate to do this, but I do need to get a lot of this content covered, so I'm going to go ahead and move on. So this is degenerative joint disease, also known as osteoarthritis. It is the most common form of arthritis. Sorry. There are no remissions, no systemic symptoms, no malaise, fever, nothing like that. It's all localized issues. It's characterized by slow and steady disease progression of destructive changes in the weight-bearing joints. So that's the key to this: hips, knees, spine, and hands. But because it's changes in the weight-bearing joints especially, one of the major risk factors include, I hope that you guys will take time to pause the video and go ahead and fill in the blanks, because you'll get a lot more out of it than just listening to me tell you the answers. But obviously, since I don't know what you're going to be doing with the recording, I'm going to go ahead and tell you. But risk factors are going to include increasing age, previous joint injury, obesity, which is a significant one, congenital and developmental disorders, hereditary factors, and decreasing bone density. All right, you've got primary and secondary OA. So primary OA occurs when there's no known etiology. Secondary is when there is an underlying etiology, such as an injury or a congenital disorder. OA is also known as the wear and tear disease. Okay. It begins when the cartilage that covers the bone end becomes thin, rough, and ragged. As the cartilage wears away, the joint spaces decrease, leaving the bones to get closer and eventually rub together. In order to repair damage, the new bone develops in the form of bone spurs, cysts, or osteophytes, which are bony projections, and then that leaves the joint obviously deformed. So here's a description here for your normal joint, and here's your joint with OA. Okay, and you can see how significantly decreased this degeneration of the articular cartilage, the inflammation of the synovitis membrane, thickened joint here, these bone spurs, very uncomfortable. All right, so assessment findings for early stage are brief stiffness and pain after a period of inactivity. So when early stage, pain decreases with activity and is relieved by rest. So that is a key for an early stage OA, that it is going to be relieved by rest. Now, once you get into the late stage, rest does not relieve the pain any longer. The client's going to have limited mobility of the joint, and crepitus can be heard and felt with the joint movement. So if you'll remember, crepitus is that popping, that snap, crackle, pop you hear a lot of times. If OA affects the hands, they may develop bony prominences on the dorsolateral surface of the interphalangeal joints. So those are going to be known as Heberdine's nodes and Bouchard's nodes. All right, so Heberdine's node, you're going to have a bony enlargement on the distal interphalangeal joints. And you have a description on page 189 in your book. And then Bouchard's node, you're going to have this bony prominence on the proximal interphalangeal joint. So an x-ray is going to show disruption of the joint cartilage and bony changes, obviously. So med-surg management is going to be local rest to the affected joints. Heat application may provide some relief. Weight loss for obese clients, that's a big one. No activity that places excessive stress on the affected joints. So no running, jumping, jump rope, jogging. These people will really benefit from exercising like swimming and things like that, or non-high impact exercises. Acetaminophen, NSAIDs, corticosteroids are going to be used. Using narcotics to alleviate the pain is not recommended, because this is going to be a chronic disease. Okay, so we don't really want them to become addicted to the narcotics. Glucosamine and chondroitin are thought to increase tissue function and interfere with cartilage breakdown. And in fact, a lot of physicians do recommend at least trying glucosamine and chondroitin. My husband takes that somewhat frequently. He's got some degenerative joint disease in his knees, and he'll take that. A TENS unit may help decrease some of the joint pain, and most clients do eventually need some reconstructive surgery. All right, obviously the most affected, the most commonly replaced joints are going to be hips and knees. All right, so nursing management, education is key. As I read through all of your all's posts this week on our discussion board post, it's clear that education is key to most everything we do as nurses, and this is no different. So go ahead and try to fill this in. If you'll pause the video, that would really help you in the long run. It's totally up to you how you want to proceed with this. But there is a table 63.1 on page 1089 that could really help you with this. Good posture can also alleviate added stress to the joints, and drug therapy and ADLs. All right, so criteria, affected age group. So for rheumatoid arthritis, it's going to affect age 20 to 40. In OA, it's going to affect usually after age 40. Affected gender. For RA, it's mostly women. For OA, it's going to be before age 45, it's going to be men, and after age 45, it's women. Onset of symptoms. For RA is going to be acute and sudden. Rheumatoid equals rapid. And for OA, it's a slow, steady disease progression. All right, joint stiffness. For RA, you're going to have morning stiffness that lasts at least an hour. And for OA, early in the disease progress, you'll have brief joint stiffness and pain after periods of inactivity that are relieved by rest. And then after, in the later stages, you'll have pain that may not be relieved by rest. Okay, so hopefully you guys filled that in ahead of time. It really will benefit you in the long run. But there's some information for you. All right, moving on to the temporomandibular joint. Looks like I have a typo in there. But it's the temporomandibular disorder. Causes are arthritis of the mandibular joint, bruxism, which is teeth grinding, or jaw dislocation. Assessment's going to be jaw pain, headache, tinnitus. Hopefully you guys remember what tinnitus is. Ear pain, jaw clicking, or jaw locks. Okay, I don't know if you all know anybody that has temporomandibular disease. I've known some people who've actually gotten their jaws stuck open because their jaw locks open. Fortunately, I haven't had that issue, but I don't know. I think I probably told you all this story before. When I chew food, like real chewy or hard foods, my husband's like, don't even eat until I turn the TV on, or he'll leave the room or something because it's very loud. My jaw clicks very loud quite frequently. So I don't know if you'll be able to see on the video here, but okay, so that's constant for me. So when I chew and eat, and I do sometimes get worried that it is going to lock up if I open too wide, especially if I'm sitting at the dentist office with my mouth open. I'm very careful not to open it all the way because I am fearful that it's going to lock and I won't be able to get it closed. Medical surgical is going to be reconstructive surgery, and I'm really not about that. And TENS units can possibly help. Now, nursing concern is the ability to consume food and maybe a mouth guard to help them, or for when they're sleeping, when the patient's sleeping, to help eliminate that teeth grinding that may be causing the temporomandibular disease. All right, moving on to gout. All right, gout is a metabolic disorder involving inflammatory reactions in the joints. It's most often affects the feet, especially, again, hopefully you guys will pause and write this down, but it's going to especially affects the big toe, hands, knees, and elbows. It affects more men than women. It does tend to be inherited. Can be a secondary disease marked by decreased renal excretion of uric acid. All right, gout's characterized by hyperuricemia. All right, that's an accumulation of the uric acid in the blood. It's caused by alterations in uric acid production, excretion, or both. And gout is very painful. I've never had it, but I've known some people that have had gout, and they're in a lot of pain. It usually affects the big toe. They can barely walk. It's very disruptive to daily life. All right, so primary causes for primary hyperuricemia. Again, hopefully you guys will pause the video. It's to your benefit. But some primary causes are going to be severe dieting, excessive intake of purines, which include organ meats, shellfish, sardines, and hereditary issues. So for your secondary hyperuricemia, Some causes are going to be abnormal purine metabolism, so your body is just not metabolizing the purine that you're intaking. Increased rate of protein synthesis with over or under excretion of uric acid. Increased cellular turnover. Now this happens a lot with cancer patients. And altered renal tubular function related to the use of diuretics. Anything, even doesn't have to be prescribed diuretics, can be things like salicylates and excessive alcohol intake that leads to underexcretion of the uric acid. Alright, so a salt of uric acid is called a urate. It crystallizes in the body tissues, causing local inflammation and irritation, and accumulation of these deposits destroy the joints, leaving it swollen and deformed. It can also lead to renal stones. Alright, so assessment findings, you're going to have sudden onset with acute pain and tenderness in one joint. The joint's going to be red, warm, very sensitive to the touch. The attack may last up to 2 weeks. The client has symptom-free period followed by another attack. So diagnostic findings, you're going to be diagnosed based on obvious clinical symptoms and hyperuricemia. And the synovial fluid that's aspirated from the joint during the arthrocentesis will contain urate crystals. Alright, there is no cure for gout. The goal of treatment is to decrease sodium urate in the extracellular fluid so that deposits do not form. Treatment options include using uricosuric drugs that promote renal excretion of urates by inhibiting the reabsorption of uric acid in the renal tubules, decreasing the ingestion of purine. So these drugs lower the uric acid levels. Alright, medications include colchicine, allopurinol, and indomethacin. And you have a table on 63.2, table 63.2 on page 1092 in your. So be sure that you understand or have read about those drugs in particular on the drug therapy table, know how they work, what they are. Right, gout's considered, I don't know if you've ever heard, it was used to be called the rich man's disease because only the rich, the kings, and people that were very well off could afford to eat these expensive meats and alcohol and things that could lead to gout. Alright, so what are major methods to prevent an acute gout attack? So again, hopefully you'll pause and take a minute to write some things down. But decreasing the sodium urate in extracellular fluids so that deposits don't form. Avoiding foods containing purine, so you're going to avoid organ meats, sardines, shellfish, mushrooms, alcohol, spinach, anchovies. Again, these are all things that were considered highly the expensive foods only the wealthy could afford. Weight loss, avoid fasting, avoid fasting, low-carb diets, and rapid weight loss because that inhibits uric acid excretion. Increasing water intake and decreasing your alcohol intake. And chronic use of colchicine, prolonged use may need vitamin B12 injections, indomethacin, and allopurinol. So you don't want to chronically use these medications that we're going to use to treat. Alright, provide specific teaching points for discharge teaching for an acute attack. We're going to use drug therapy, so NSAIDs, ibuprofen and indomethacin. Colchicine is every 1 to 2 hours until pain subsides or when nausea, vomiting, and diarrhea develops. We're going to avoid salicylates. Now, why are we going to avoid salicylates? Number one, what are salicylates and why are we going to avoid them? So we're going to avoid them because they inactivate uricosuric drugs. Alright, we're going to encourage a diet with complex carbs to increase the urate excretion. So we want to limit organ meats, limit shellfish, mushrooms, alcohol. Things we do want to eat are high carbs, potatoes, whole grains, peas, pastas, veggies, things like that. Alright, fibromyalgia. Fibromyalgia. I'm sure many of you have heard of fibromyalgia. It is a chronic syndrome of pain, fatigue, and sleep disturbances. Syndrome affects muscles, ligaments, and tendons. Pain receptors in the brain develop a memory of the pain that are more sensitive to the signals. So the CNS, that central nervous system sensation, lowers the client's pain threshold. The syndrome affects men, women, and children. However, middle-aged women are more prone to developing the syndrome, and I know several middle-aged women who have fibromyalgia. Assessment is the American College of Rheumatology identifies 18 tender points on palpation that are sensitive, and if the client has 11 of the 18 tender points, that's considered diagnostic for fibromyalgia. It's usually made by symptoms. There are no specific tests. That the testing that they would do for fibromyalgia is basically to rule out other ailments, other complications, and then that's how they'll make the diagnosis for fibromyalgia. All right, fibromyalgia usually gets better through the day and worse at night, and also gets worse with weather changes. All right, symptoms include fatigue, sleep disturbances, IBS, irritable bowel syndrome, chronic headaches, depression, anxiety. All right, medical management. It's going to be taking the prescribed medications, including analgesics, muscle relaxants, and tricyclic antidepressants. Drugs like amitriptyline sometimes have success for chronic pain. Lyrica is an anti-seizure medication, but it is the first drug approved by the FDA to treat fibromyalgia. So clients may also benefit from alternative therapies such as acupuncture and massage therapy or chiropractic therapy. Nursing management is going to include providing emotional support, encouraging a healthy lifestyle. Really, emotional support is key for patients with fibromyalgia because they often feel like no one's listening to them. In fact, for a long time there, that fibromyalgia wasn't even a diagnosis. It was just people complaining about these vague symptoms. But because there's no test to say, yes, you have fibromyalgia, it was very difficult for diagnosis. So emotional support is very key for this diagnosis. Okay, moving on to bursitis. All right, here's a picture of bursitis. It's an inflammation of the bursa, the fluid-filled sac that cushions the bone ends to enhance the gliding movement. So it causes, for bursitis, include trauma or overuse, stress, infection, or secondary effects of gout and RA. Oftentimes it affects elbows, shoulders, knees. Okay. The assessment is going to be painful movement of the joint. If the bursa ruptures, the area may become warm and edematous. There's a distinct lump felt on bursitis. Medical and nursing management, joint rest is most recommended. Prescribed medications such as salicylates, NSAIDs, and or corticosteroid preparations. So in this one, we do want to use some salicylates. The client will need education of medications and the disease process. If infection is the cause, the patient's obviously going to need some antibiotics. Need to be sure that you read pharmacological considerations on page 1094. After the pain and inflammation decrease, ongoing therapy involves mild range of motion exercises. All right. SLE, systemic lupus erythematosus. Here is a picture of the classic butterfly rash that's associated with some systemic SLEs. So it is a diffuse connective tissue disease affecting many body systems, skin, joints, kidneys, serous membranes of the heart and lungs, lymph nodes, and the GI tract. All right, it is more common in females. In the 3rd and 4th decade, there's strong family history. It is believed to be autoimmune, where antibodies destroy connective tissues of the body. On assessment, it is known as the great imitator due to the symptoms resembling other disease processes, so it's important to know that. It is marked by different remissions and exacerbations, so it's not constant. They'll have remissions and then exacerbations. Early symptoms include, again, I hope you'll pause and write some of these down yourself before I just tell you. But early symptoms are going to include fever, weight loss, pain in the joints, muscle pain, extreme fatigue that persists for a long time before other symptoms develop. All right, half of the clients experience a red butterfly-shaped rash known as, again, I hope you'll look that up, but it's known as a malar rash, M-A-L-A-R, on the bridge of the nose and the cheeks. The rash gets worse in the sunlight. Then we have discoid lupus erythematosus, DLE. It's a chronic rash with erythematous papules or plaques and scaling. The most prominent appearance is a facial rash. Also can be found on the forehead, earlobes, and scalp with some alopecia. It's a flat red rash, and it heals with some scarring though. Then subacute cutaneous lupus erythematosus presents as a papulosquamous lesions. Again, I've got a typo in there, but it's papulosquamous lesions. The rash is raised and scaly. So be sure you see box 63-2 for all clinical manifestations of SLE on 1095. There's pericardial friction rub, EKG changes, enlarged spleen, so enlarged lymph nodes, weight loss, many different things. So be sure that you understand very well what you would find, what you would identify for these different types of lupus. Okay, we've got SLE, systemic lupus erythematosus, discoid lupus erythematosus, subacute cutaneous lupus erythematosus. Okay, and they present with some different findings. All right, diagnostic findings are based on symptoms and blood tests. The anti-double-stranded DNA shows high titers of antibodies against native DNA. So this test is not positive for other autoimmune disorders, making it this test SLE specific. So if you're going to test specifically for SLE, then you're going to do this anti-double-stranded DNA test. The American College of Rheumatology has identified 11 different criteria for SLE. Clients with 4 of these criteria are diagnosed with probable SLE. So if you'll remember the fibromyalgia, there were 18 criteria and you had to have 11 of them. And SLE, there are 11 criteria and you have to be diagnosed with 4. The criteria include, again, I hope you'll look this up for yourself, but I'm going to go ahead and tell you as well. A malar rash, discoid rash, photosensitivity, oral ulcers, arthritis, pericarditis, renal disorders, neurological disorders, hematological disorders, immunological disorders. This is all on page 1096 in your book. Medical management is that there is no cure for lupus. The goal is to produce remission and prevent exacerbations, and drugs include high-dose corticosteroids, NSAIDs, cytotoxic drugs, and antimalarials such as Plaquenil is an antimalarial. All right, musculoskeletal infectious disorders. Osteomyelitis. This is an infection of the bone. Osteo is bone, myelitis, infection of the bone. So it results when there is bacteria that reach the bone via the bloodstream. Staph aureus is the most common cause. It's 70 to 80% of bone infections are caused by Staph aureus bacteria. You have acute localized osteomyelitis occurs when the bone is directly contaminated with bacteria from a trauma or from surgery. Microorganisms migrate just below the epiphysis of a long bone. So if you need to go back to the very first lecture where we did bone anatomy. But they migrate just below the epiphysis of a long bone due to increased blood supply. And as these microorganisms multiply, they spread down to the shaft. An infection lingers in a chronic state. It's difficult to penetrate the infected tissue by systemic antibiotics, therefore weakened and increased incidence of fractures from the bones. Assessment findings are symptoms of acute infection are going to be fever, chills, tachycardia, redness, swelling, your normal things of an acute infection. Now, chronic infection may include a persistent draining sinus, so you may have a sinus tract through the skin that may develop, and that's how you know that they have osteomyelitis. I mean, it's very interesting. Blood work, x-rays, MRI, bone scans can all help us determine if the patient has osteomyelitis. What test would show that there were infection? Again, I hope you'll pause and look up some of these answers. But if we do some blood work, we would see some increased leukocyte count, increased ESRs, positive blood culture for infective organisms if we did blood cultures. Now, an ESR, again, is erythrocyte sedimentation rate, so it measures how much inflammation is in the body. All right, medical surgical management is going to be immobilization with a cast to prevent pathological fractures, warm saline, soaks to the affected area for 20 minutes several times a day, which will help increase the blood circulation around the area. Identification of the causative organism, initiation of IV antibiotics up to 6 weeks. They may be on IV antibiotics for up to 6 weeks, and then oral antibiotics for up to 3 months. I mean, this is a serious infection that's very difficult to control. Surgical debridement of necrotic tissue and sequestrium to remove the infected area. And we may do closed irrigation with saline or antibiotic solution with suction to flush out the necrotic tissue. We may do bone grafts to stimulate bone growth in the debrided bone, and muscle flaps to the affected area to increase circulation. So this is a very serious disorder, obviously, if we get some osteomyelitis infection of the bone. Difficult to control, difficult to treat. It's not just a matter of giving systemic antibiotics. We've got to really treat deep into the bone. All right, structural disorders. Osteoporosis. Osteoporosis is a loss of bone density, occurring most often in older, thin-framed Caucasian women. African American women have a greater bone density, thus making them less susceptible. Loss of bone substance exceeds bone formation. Bones become porous, brittle, and fragile from bone mass and density reduction. And causes include things like family history, smoker, chronic low calcium intake, excessive caffeine intake, which I'm pretty sure a lot of you guys fall into, excessive caffeine intake category, high doses of corticosteroid use, hyperthyroidism, hyperparathyroidism, eating disorders, malabsorption syndromes. Estrogen deficiency, which occurs at menopause, is considered the leading factor in osteoporosis among aging women. Okay, so postmenopausal women have a great risk of osteoporosis due to the estrogen deficiency. All right, assessment findings. We've got lumbosacral pain, thoracic pain, or both from tiny compression fractures in the vertebrae. A loss of height, which is known as progressive kyphosis. This happens a lot of times with elderly people, and they start getting the hunchback, that progressive kyphosis. 25% of bone loss is evident on x-ray. That's a diagnostic finding for osteoporosis. Now, medical management would be calcium-rich and vitamin D diet can help prevent osteoporosis. So oral calcium with vitamin D supplements are better absorbed than those without. Okay, so if you take oral calcium with vitamin D, it's better absorbed. So taking oral calcium with meals to increase absorption and decreasing gastric upset is really important as well. The disease cannot be treated directly, but management can decrease bone reabsorption. So there's no treatment per se, but there is some management. Medications include biophosphates. These are things like, again, I hope you'll pause and look this up yourself, but I'm going to go on. These are things like Fosamax, which inhibits bone reabsorption. You take it once a week or monthly to decrease GI upset. Calcitonin. It inhibits bone reabsorption and slows bone loss. It's usually done in a nasal spray, but may be given sub-Q. And selective estrogen receptor modifiers, SCRMs. Example of this is like Evista. They preserve bone mass density, therefore decreasing the risk for osteoporosis. Okay, so be sure you understand these medications, how they work, what they're used for. We've also got hormone replacement therapy. So it's not used as much anymore, actually related to uterine cancer and heart disease risks with hormone replacement therapy, but it is an option. Then we've got teriparatide or Forteo, which is given to people at high risk for fractures. It stimulates some bone growth, and it's given once a day by injection. Oops, sorry. Tamoxifen or Nolvadex reduces the risk of fractures. It's used primarily for women with breast cancer or who are at increased risk for breast cancer. Other treatment focuses on relieving pain and preventing injury, so nursing management is going to be what types of things? Again, hopefully you've done this on your own, but a well-balanced diet high in calcium, vitamin D, and protein to prevent osteoporosis. Promoting activity that helps bone formation, such as weight-bearing exercises. Walking is a really good weight-bearing exercise. Okay, I have probably told y'all this story, but anyway, when I fractured my feet, both of them, I just happened to be going in for my annual exam, and my doctor said, what's going on? I had my foot in a cast, and I told her what had happened both times, and she said, something's not right. You shouldn't be fracturing like this. So we did a bone scan, but at that point it was really a big deal about whether or not insurance was going to cover the bone scan, because I was not of age, I was not postmenopausal, I didn't fall into these categories for having osteoporosis. But we went ahead and took the risk, and did do the bone scan, and I do have osteopenia, so it's a mild, I'm on the road to osteoporosis, basically. So of course insurance covered it because it did show that there was some bone loss issues. So I do take vitamin D and calcium supplements, but what I did find is very true, that you do want to take the calcium with vitamin D and with food or at night, because it can really upset the stomach and really deter people from taking the treatment, as well as walking and doing these weight-bearing exercises is very important for these patients. All right, so stop and think. What kind of diet would you recommend to a client recently diagnosed with osteoporosis? Again, I hope you'll pause here, but I'm going to go on and tell you. Appropriate recommended levels of calcium with vitamin D. Smokers are going to require more of this. Vitamin D foods are going to include things like fatty fish, egg yolks. We're going to want diets high in salt. No, we don't want diets high in salt, caffeine, and sugar, because these are associated with more bone loss. Decrease salt, caffeine, sugar, adding fruits, veggies, dark leafy greens. These are all high in calcium. These are things we want to add to our diet. All right, osteomalacia. This is a metabolic bone disease. It's a vitamin D deficiency causing bones to become soft. Generally, they're soft, or insufficient calcium. It could be caused from insufficient calcium absorption caused by insufficient intake or resistance to vitamin D. So large amounts of new bones fail to calcify. The bones are structurally weaker, and bone deformities then occur in these patients. So assessment findings, we're going to find that the bone is very weak, painful, tenderness upon palpation to the bones. As the disease advances, we see kyphosis and bowing of the legs, and the clients exhibit a waddle-like gait, making them at a fall risk. So what measures should the nurse take to prevent falls? Again, we're going to put the sign on the door if they're hospitalized, the call light within reach, remove any floor hazards, any rugs, coffee tables, things that may be in the way. Have a bedside toilet if we need it. Assisting with their ADLs, put the bed in the lowest position, and make sure that bed alarms are on for the patient at a fall risk. So this is a very good picture of osteomalacia. So this is your solid bone matrix, and you can see how nice and formed and concentrated that is. And then we have your weakened bone matrix here with osteomalacia. Okay. Medical and surgical treatment is going to be correcting the underlying cause. Where is the deficiency? Calcium, vitamin D, and phosphorus supplements. Sunlight is a big thing. Exercise and ambulation to promote bone formation. And nursing management is going to be disease education. Okay? So I know I'm running through this all very quickly. I'm sorry about that, but I do need to get through this. So if you guys have questions on this, please email me. We'll put it, I'll put it on a discussion forum if we need to, so that we can talk about things so that everybody's clear on these topics. All right, Paget's disease. Paget's disease has an unknown cause, unknown etiology. It is a chronic bone disorder characterized by abnormal bone remodeling, most often in the long bones, the spine, the pelvis, and the skull. It occurs in adults over the age of 60. There is a disturbance in the ratio between bone formation and reabsorption. So the process of bone turnover causes a mosaic pattern of bone matrix development. So the new bone is not well formed but has a very high mineral content, and this causes the bone to be weak and prone to fracture. So what are some complications with Paget's disease? Obviously, we're going to have some pathological fractures. We may have paralysis from spinal cord compression. We may have some cranial nerve damage. And kidney stones are also a complication from Paget's. So here's your normal bone in development. And here is Paget's disease. Okay. All right, so upon assessment, some clients are going to be asymptomatic with only mild skeletal deformities. We have bone tenderness upon palpation. The disease may actually go undiscovered until x-ray for other issues reveals the disorder. And when we do an x-ray, we're going to have this mosaic pattern to the bone structure. Excuse me. Medical surgical management. Clients without symptoms often do not require treatment. Drugs are going to include analgesics and calcitonin or calcimer. So what do you remember about calcimer? We've already discussed that. Hopefully remember that it inhibits bone reabsorption and slows bone loss. And things like bisphosphonates, actinol, they inhibit biphosphonates such as actinol, they inhibit bone reabsorption. All right, surgery may be needed to repair pathological fractures, replace damaged joints, and realign deformed bones, or to relieve neurological complications with Paget's disease. All right, moving right along, kind of quickly. Disorders of the feet. Hallux valgus, also called a bunion. I know people have heard of bunions before. So this is a deformity of the great toe at the metatarsophalangeal joint, so where it connects to the foot bones. Bunions are localized enlargements of bone and tissue on the sides and or top of the joint at either the base of the big toe or the smallest toe. So most often people think of bunions being primarily only on the big toe, but they can be on the small toe, and I do have that issue myself as well as my children with the bunion on the small toe. All right, then we've got hammer toe, which is a flexion deformity of the proximal interphalangeal joint, and it may involve several toes. We've got mallet toe, which is a flexion deformity at the distal interphalangeal joint. And it can result from, any of these can result from poorly fitting shoes. It can also be from arthritis, and it can be hereditary, which is unfortunate that my children have inherited it from me. So, here's your bunion on your big toe. All right, and here's a picture of it. Here's your hammer toe. Okay, and you can see how this could be uncomfortable in your shoes as well, as you live with these ailments. And here's mallet toe. Okay, hammer toe and mallet toe. Flexion at the proximal and distal interphalangeal joints. Assessment findings. Clients with bunions have pain with walking or flexing the foot, tenderness and redness of the joint. The foot deformity is very obvious. So with hammer toe and mallet toe, the deformity is also obvious. The patients get corns, calluses on those toes that are visible, and the client complains of a lot of pain with walking. An x-ray obviously will reveal severe joint deformity. So medical surgical management for the bunion is properly fitting shoes with a very low heel. You don't want anything that's causing more pressure. If you wear high heels, that causes more pressure on that joint there, right here. And so we don't want anything that's going to cause more issues right there. The deformity can actually be corrected with a bunionectomy. I do have a friend that did have a bunionectomy. They usually just do one foot at a time. And, you know, I don't even think, I'm trying to remember, but I don't think she went back and had the other foot done. She had one done, and I don't think she ever went back and had the other one done. Hammer or mallet toe. Medical surgical management is going to include things with exercise. Properly fitting shoes with the open toe will really help. Pads to protect the joints. And surgery can correct malalignment. It is an outpatient surgery. They go home the same day. They're discharged home with rest and analgesics and elevation of the foot. Right, nursing management is obviously going to be to relieve pain and discomfort, improve the patient's mobility, instruct on the need for properly fitting shoes, because this is a big thing, especially for women. It's all about what the shoe looks like, although I have to say men are just as bad about what the shoe looks like, but they aren't wearing dress shoes and high heels and things like that. So making sure that you're wearing properly fitted shoes. And then be sure that you go over client and family teaching on page 1104 in your book. All right, bone tumors. Benign bone tumors are usually benign or more common than malignant bone tumors. They're usually non-life-threatening, but they do have the potential to cause fractures. These types of tumors do not metastasize and are the result of misplaced or overgrown clusters of normal bone or cartilage cells that cause the structure to impair and enlarge and impair functioning. So assessment findings obviously is going to be pain, discomfort that increases with weight bearing. X-ray, bone scans, and biopsy will help to determine the diagnosis. All right, medical surgical management is going to be treating the pain, obviously. Preventing any fractures is key. If the tumor continues to grow, surgery does need to be performed. Bone grafts may be needed to promote bone growth and healing. We may do splints and casts until the bone heals. And benign bone tumors can reoccur, so a client does need to be monitored very closely. All right, the nurse is responsible for education, which is very key in these issues. All right, here's a picture of bone tumor for you. All right, now, malignant bone tumors. Malignant tumors are either primary or secondary. A primary starts in the bone. A secondary is where the cancer originates in another location of the body, you know, lung, breast, kidney, and then travels to the bone. So malignant bone tumors are abnormal osteoblasts, which are cells that make bones, or myeloblasts, which are marrow cells that exhibit rapid and uncontrollable growth. All right, so previous exposure to radiation and toxic chemicals has been associated with some malignant bone tumors, a hereditary link with an absent or impaired tumor suppressant gene. Malignant tumors are located in distal femur or proximal fibula and some in the proximal humerus. So metastasis via circulatory or lymphatic system. That's how these tumors or these cancers metastasize. All right, so assessment findings, we may have pathological fractures, may be the initial reason that the client seeks treatment. Client has persistent pain, swelling, difficulty moving the extremity. They may have a limp or an abnormal gait. By the time the client experiences pain, the tumor is usually spread beyond the primary site. So X-ray, MRI, and bone scans reveal the abnormal bone, and the biopsy reveals abnormal cells. Medical surgical management for a primary malignant tumor may involve removal of the tumor by amputation of the extremity or by a wide local resection where they'll just take out a large section of the bone and replace it with metal instruments, or they may just make that extremity shorter. Limb sparing surgery is more common. They do try to spare the limb as much as possible. So chemotherapy and radiation aims at destroying tumor cells that escape from the original tumor site. in nursing management is that this client definitely needs extensive emotional support, education about the disease, treatment, and prognosis. Because again, as we said earlier, most of these people don't even realize they have anything until they go in for something else, and then they realize, oh, we've got a big problem here. So I've told you guys about my friend with the, well, we're going to talk about that in peds. I'll talk about that later when we do pediatrics. So I think that pretty much finishes up all of the orthopedic things, and that should leave us just with peds, if I'm not mistaken. So next Monday, we'll cover all of peds, I hope, and I may have to record some of that as well. And that will be, let's see, next Monday. Yeah, I'm so confused. This information that I just lectured on will be on exam, whichever exam, give me a second, sorry. I had this all in my head and then I got confused. Oh, what day is today? Okay. This information that I just went over on this PowerPoint, on this recording, will be on exam 4, which will be Monday, September 12th. So everything I just went over, finishing up that PowerPoint that we had started, is going to be on exam 4, Monday, September 12th. Then I will lecture Monday, September 12th in the afternoon, and we'll do pediatrics. And all of that content plus all the other content that we've already gone over will be on the final exam. Okay? So if you have any questions about that, please let me know. Send me an email and so that I can be sure and clarify for everyone what we're going to be doing. All right. Thanks, guys.